Hello everyone. I hope that you all are doing fine. So we will start with today's topic, which is the oral mucosal disease that we need to cover. This is also a very important topic that you need to learn by your heart. Okay, and you can expect few scenarios from this whole chapter, from this whole topic. Okay. So first we will start with assessment of oral mucosal disease, like how it can happen and how to assess it. So we will be reading that and then we would read some more important things. Then the oral mucosal lesions are common. We all know, like that's the reason we do, even the patient comes for general checkup, we do check their soft tissue and hard tissue because these things are very common, and there could be few reasons why they might be happening. Firstly, it could be due to physiological changes, then local disease, or an oral manifestation of a skin condition, an adverse drug reaction, or systemic disease such as git disease. Okay, so, successful management of an oral mucosal disease requires an accurate diagnosis. When you can diagnose a problem, then only you can manage it, right? So, if for the successful management, you need to make an accurate decision or accurate diagnosis. Assessing an oral mucosal lesion involves taking a full patient history. So, when you need to assess any lesion or anything, what are your steps that we learned in chapter 1? Is first you need to take a full history, then you need to do the examination, you need to start extraoral and then intraoral examination, then you will do certain investigation to make sure or to make confirm your diagnosis. Investigations would include like whether you need to take an x-ray or you need to do the biopsy. So these are some things that you need to do. Where appropriate, have a high index of suspicion for oral cancer. Whenever there is any risk factor, we will read like which risk factor they are talking about, but always have a high suspicion of oral cancer, because you all know like every disease or even the cancer, when it starts at initial stage, it is very small, it is just like normal. We If we ignore it at that point, or it does not get treated at that stage, that's the time when it progress or it spreads and it becomes into stage 2, stage 3, and lastly you all know that it would be beyond our domain to work on that. So we need to be as a dentist, because mouth is a gateway of the systemic disease. Sometimes we can find something in the mouth which is happening inside the patient's body, like for example the relation between gum health and the diabetes, right? So if the patient has poor diabetic control, he would have high risk of getting the gum issues. So we need to educate these things to the patients. So we need to work very hard and we need to be very cautious what is actually going on inside the patient's mouth. So here they have mentioned few things, that if you see any red flag, we will read what are red flags in the next page. And if the diagnosis is not clear, you are not sure whether this diagnosis is confirmed or not, or if the patient has not responded, you did your initial treatment, but patient has not responded to your treatment, then what you need to do is refer him to the appropriate specialist. Okay, and who will be the appropriate specialist? He would be an oral medicine specialist, is the most appropriate specialist to diagnose and manage oral mucosal diseases, but may not be accessible. So the best one is the oral medicine specialist, but if it is not accessible, then you can try with the oral surgeon or dermatologist or otorhinolaryngologist. Sorry about the pronunciation, but yeah, so these are the things that you can try, but the best one is the oral medicine specialist. Okay. Then some oral mucosal diseases are associated with significant morbidity and mortality, particularly oral potentially malignant disorders and oral cancer. So oral potentially malignant disorders include which are the potentially malignant disorder, means that they have the capability that they can turn into malignant. So they those are mainly oral leukoplakia, erythroplakia, chronic hyperplastic candidiasis, actinic colitis, oral lichen planus, oral submucous fibrosis, and discoid lupus erythematosus. And you know, you will get all these all topics are covered in Odell as a case, as a scenario, so you can read in more detail from Odell. Okay, and red flag features of oral mucosal disease, which are those. So I made this like a trick for me, so it might help you guys. So these 3 points are for ulcers only. First, the ulcer which are present for more than 2 weeks. Second, the ulcer which has reoccurred. Thirdly, the ulcer which has happened in children, but it is non-traumatic. Okay, so non-traumatic oral ulcer. So these three things, they are a red flag feature. So if there is any red flag feature in any patient, so what you need to do is refer him to the specialist. Then pigmented lesion, or any red white or mixed red white lesions, because you know that the white lesion could be leukoplakia and the red lesion could be erythroplakia. Okay, so you need to be more cautious about that. And if they are showing potentially malignant features, which are the malignant features? Induration, the borders are indurated, ulcerated with rolled margin, fixation to the underlying tissue, like the cancer or the malignancy is mainly fixed to, they have a fixation, they are not moving the tissues. Okay, and the lesion in high risk site. For example, if the patient has any ulcer which has indurated margin or the rolled margin, and it is present on the lateral surface of the tongue or on the floor of the mouth, these are the sites which has a high potency to turn into malignant. So then you need to just refer him urgently to the specialist. Okay, and the other thing is the paresthesia. You all know that this numbness or the paresthesia is a characteristic sign of oral cancer or any cancer. Persistent oral mucosal discomfort with no, you cannot find what is the cause in patient's pain, or like sometimes what happen, like even if the patient comes to you, like he has got a extraction done, but the socket is not healing and it's been so many weeks now. So sometimes it could be like there could be any cancer in that jaw that might be despairing the healing process. So it can occur if you are not sure, and if your patient is not responding, then you just need to refer him to the specialist. Okay, then the other things are if there is any lumps or swelling, or if the lymph nodes are enlarged. Okay, so there are some characteristics that when you do the examination of the patient, like you check their lymph nodes. So with the lymph nodes, you know that if their lymph nodes are tender and they are moving, and there are some certain signs that would denote towards infection, and certain signs that would denote towards the cancer. Okay, so the cancer lymph nodes would be fixed, they would be hard, and there would not be pain, they would not be tender. Okay, then swelling, pain, or blockage of a salivary gland suggestive of salivary gland disease, suspected allergy or adverse reaction to any dental material. So these are all the signs that you need to remember, that could be one of the reason that you need to refer the patient to the specialist. Or the patient has a dry mouth which that is not adequately relieved with artificial, he has tried certain procedure, or you did give him the initial management by giving him some artificially salivary product or non pharmacological methods like asking him to sip the water throughout the day or take much amount of water like around 1.8 liter per day, or try some chewing gums, but still that is not helping. So if you are not helpful for the patient, so the last resort we have is referring to the specialist. And then the dry mouth that caused by the systemic disease. Then suspected oral manifestations of systemic disease, example syphilis, Behçet syndrome, HIV, inflammatory bowel disease, or lichen planus or pemphigoid. Okay, so these are the oral manifestation of systemic disease, or if the lesions occurring in immunocompromised patients, such as patients with neutropenia or HIV patients. Okay, so I would say like read this table few times so that you would remember which things you really need to focus. And if you see these things in any scenario, then the best answer would be referring to the specialist. Oral potentially malignant disorders can become malignant at the site of the lesion, but also predict an increased risk of cancer at other sites in the mouth, even in clinically normal appearing mucosa. Okay, so malignancy can happen like the primary malignancy and secondary malignancy, right? So if some cancer has originated from one part of body, it can either spread to uh, that part only, or it can travel through either through the lymph nodes or through the blood to the other part, and it can spread. The following conditions can be managed in general practice. So, as a general dentist, what you need to manage is what we will read in this whole chapter, in this whole topic, which is the recurrent aphthous ulcer. You can manage it, but there is a condition, which is there should be no red flag features. Okay, so there should be no red flag features, then only you can manage. Otherwise, there needs to be an referral to the specialist. So, which are the condition that you can manage as a general dentist, which is the recurrent aphthous ulcerative disease, recurrent aphthous ulcer, then traumatic oral ulcers, oral candidiasis, angular cheilitis, oral mucocutaneous herpes simplex virus, dry mouth. I'm just reading them because we will discuss them in detail in the following pages. Okay, we will discuss each and every topic in detail, what we can do. Oral mucositis and amalgam tattoo, then geographic tongue, hairy tongue, and there are some physiological causes also of the oral mucosal discoloration, such as Fordyce spots, ectopic sebaceous gland, or the leukedema, which do not warrant any treatment. You just need to make confirm the diagnosis. They do not need any treatment. Okay. So the oral cancer. Oral cancer is associated with significant morbidity and mortality. Early presentation of oral cancers are usually asymptomatic, whereas late presentation include early presentation would be very small and tiny. The patient would think like this is only a like after ulcer, or is this is only a traumatic ulcer, or this is just a normal thing. I'm not worried about this, or people would say like that. But and because the late presentation would include the pain, discomfort, or the reduced mobility of the tongue, but the increased mobility of the teeth, or inability to wear a denture. Or if the patient would complain like I cannot wear this denture, or he would like every time you are doing the adjustments but still he is not happy, so you could think about, or you could be suspicious that there might be any cancer originating in that jaw or from that area. Okay, then oral cancer varies in appearance and can mimic many other mucosal diseases. See photo 2, 3, and 4. So this is present on the left ventral surface of the tongue. This is present on the right anterior ventral surface of the tongue. So you can see that each and every picture, so the appearance is different, right? So it can vary. Then any suspicious lesion needs early specialist referral for investigation and biopsy. So whenever you are suspicious, so what you need to do is refer to the specialist as soon as you can for the investigations and biopsies. So the specialist would do the investigations, and he will do the either the biopsy, or like he would choose either he needs to do the incisional biopsy or excisional biopsy or brush biopsy or any other type of investigations. Okay, then squamous cell carcinoma is the most common oral malignancy which arises from the epithelium of the oral cavity. Oral squamous cell carcinoma can affect any part of the oral mucosa. However, it is most commonly occurs on the lateral surface of the tongue, the floor of the mouth, or the gingiva. So that's the reason these are a high risk site. So this is the most common type of ulcer which happens in the oral mucosa, and the more common site are lateral surface of the tongue, floor of the mouth, and gingiva. Okay, so you need to be more cautious if there is any lesion or any ulcer on these sites. The risk factors include if their advanced age, male gender, if he is using tobacco or smoking, and alcohol, infection by oncogenic viruses such as human papilloma virus, personal or family history of squamous cell carcinoma of the head and neck, history of cancer therapy, or prolonged immunosuppression, or recurrent or betel quid chewing. So these are some of the risk factors which can put the patient to a risk of getting squamous cell carcinoma. Genetic susceptibility, environment, occupation, and diet may also contribute to the development of oral squamous cell carcinoma. Okay, so sometimes due to the genetic, like because these things do run in family, so sometimes due to genetic or due to the environment, because if someone is living in the very polluted or industrial environment, then the chances of getting this cancer is more. And even the occupation, if the like the factory worker, or if the job is very stressful, and you all know that the stress can really lower down your immunity and can pose you for getting all of the like ill effect, or it would not be, it is not healthy for your body. And sometimes even diet as well, because if you will not maintain good diet and your diet is not good, it can lead to, and it can lead to some health ill effects. Okay, so they can be contributing factors. Cancers originating from the salivary glands and supporting non-epithelial tissues are less common than squamous cell carcinoma. Metastatic cancers to the oral soft tissue and jaw bones originate primarily. So, as we read before, like they could show the property of metastatic, which is originally their site was either start from the breast, prostate, kidney, or lungs, but now they are showing up in the mouth as squamous cell carcinoma. So they do these things, and even the leukemia and lymphoma may also be present in the oral cavity. Okay, then these are some of the pictures. And then oral leukoplegia. So it is a clinical term for a non-removable white lesion that is not easily recognizable as any other. First, you need to think about, like, it could be like candidiasis, it could be lichen planus. So you need to first rule out, and if it is not easily recognizable as any other particular condition and therefore requires further investigation. Oral leukoplegia, it there are few types of oral leukoplegia. First is homogeneous, which means that uniform lesion on often with a fissured surface, or it could be non-homogeneous with a surface of irregularities. Okay. Some oral leukoplegia lesions shows histologic evidence of dysplasia, which is a sign of cancer, and carcinoma in situ or invasive squamous cell carcinoma. The malignant transformation rate. So you just, for this topic, you just need to be, what you need to gather from here is that first you need to understand what is leukoplegia. Then it can turn into cancer, and there is a range of about between 0.13 to 34%, with the mean annual transformation rate value is 3.8% per year. So what you need to do for these type of patient is refer them for the specialist to do biopsy and monitoring. So specialists would be handling them from now. Biopsy of a persistent undiagnosed oral white patch is required to exclude epithelial dysplasia. So they would do the biopsy. Why they would need to do the biopsy? That they to exclude epithelial dysplasia, carcinoma in situ, or squamous cell carcinoma. So these are the stages. So first will be the mild dysplasia, then moderate dysplasia, then would be the carcinoma in situ, then would be the squamous cell carcinoma. So these are the stages that would biopsy would help to find out what is the stage in that particular patient. Then oral erythroplakia, it is a clinical term for a potentially malignant fiery red lesion that cannot be attributed to any particular condition. Lesions are usually asymptomatic and isolated and commonly appear on the floor of the mouth, tongue, soft palate, and buccal mucosa. So this is its most common site to occur, which is the floor of the mouth, tongue, soft palate, and the buccal mucosa. Okay, so lesions may appear as smooth, velvety, granular, or nodular plaques, often with clear margin. Oral erythroplakia most commonly affects middle-aged and elderly women, but it has transformation rate which is very high, which is 70 to 90%. So here you need to do the urgent specialist referral. Okay, so in case of leukoplegia, you are just referring them to the specialist because the rate is 3.8% per year. But here the rate of transformation is 70 to 90% are carcinoma in situ, so you need to do the urgent specialist referral. Okay, then periodic review and repeated biopsy by the managing specialist is recommended for all patients with oral erythroplakia because malignant transformation is very common in erythroplakia. Okay, so the biopsy, it is a question which can happen, which can come in exam, which is who would do the biopsy. Mainly, the treating specialist should perform the biopsy, but in rural or in remote areas where a delay in specialist review is expected, then you can take specialist expert advice on doing biopsy technique. And this is a type of biopsy which is the punch biopsy. It is not recommended. Okay, so tomorrow we will start from this page and this topic, which is the human papilloma virus. Okay, thank you so much, guys, for watching my video, and we'll see you next time. Thank you.